Mm, if you make your own plan, then you can you can plan accordingly. But my suggestion, if you are able to continue with me, then you can start with me. So whenever, because now today, suppose we will read pathology, and hopefully we will try to finish the maximum we can, including the new. New, I don't know how much we can do, but we have to do. See the screen, because this is my note from where I prepare. If you have your own, okay, so the new mocks, whatever new, I know new things are not very huge in amount, but even yeah, yesterday while we were discussing, new topics were there in the head and neck. Yes, but most of the thing you were not there, especially the pictures, especially the pictures. Don't worry, I understood. I understood. Don't worry. Anatomy, new questions. Anatomy. I will revise again. I will revise again. That time you must be there. The new Sala mock, new question. I collected everything. Mm-hmm. Yeah, I have seen that one. Yes, yes, yes. I have a look. Not much, not too much, not too much, and it is doable. Even it one in one day, and we will do it. All we will revise again. Anatomy minimum. I wish, I pray that I would be able to revise 2 times more before I go to exam. At least 2 times, because pathology. Yeah, after tomorrow. After tomorrow. Okay, let's do some bank work and this thing. I was also waiting. Anyway, we can start pathology. The same 56-year-old lady with bicuspid aortic valve is admitted for. Okay, so it will be your revision also. Because bicuspid valve has only two valves, which increase the risk of stenosis and stasis of the blood. Uh, in bicuspid valve, there will be narrowing, and which causes stasis, and it increases the chance of bacterial colonization and damage the tissue. With recurrent attack of inflammation, then it will progress to fibrosis and narrowing and stiffening of the valve, which can lead to stenosis. Again, there is narrowing, which causes stasis of the blood, and it increases the chance of bacterial colonization. And if there is bacterial inflammation, repeated attack causes inflammation and will be progressive fibrosis, and it causes narrowing and stiffening of the valve, and it leads to stenosis. Esophageal or transthoracic. So transthoracic or transesophageal 2D echo. In echo, we will look for valvular regurgitation, leaflet prolapse or thickening, chorda tendini elongation or rupture, annular dilatation, increase the echogenicity of the subvalvular apparatus, pleural pericardial effusion, and ventricular dilatation and dysfunction. Valvular regurgitation, leaflet prolapse and thickening, chorda tendini elongation or rupture, annular dilatation, increase echogenicity of the subvalvular apparatus, pericardial effusion and ventricular dilatation and dysfunction. Again, valvular regurgitation, leaflet thickening and leaflet thickening and Prolapse, annular dilatation, chordae tendineae rupture or elongation, increased echogenicity of the subvalvular apparatus, pericardial effusion, ventricular dilatation, and dysfunction. Myocardial infarction and rupture of the aortic dissection. Clin- Clinical picture. In mild aortic stenosis, patient will be asymptomatic. In moderate angina, syncopal attack, angina, and dyspnea. And severe case, complications like pericarditis, MI, and sudden death. Okay. As the aortic valve progresses to sclerosis and stenosis, the left ventricle and counters chronic resistance to systolic injection. It increases afterload, thickening of the left ventricular wall, hypertrophy, effects of the high left ventricular afterload will decrease the left ventricular myocardial electricity and coronal blood flow and increase myocardial workload, oxygen consumption, and mortality. So in aortic stenosis, there will be a sclerosis which progress to stenosis and hypertrophy, and it increases the afterload and it reduces the elasticity, so decrease coronary blood flow, and it increase oxygen consumption and myocardial workload. It increase myocardial workload, oxygen consumption, and mortality. Again, in aortic infective endocarditis, there is sclerosis which leads to stenosis, and it causes left ventricular hypertrophy. It reduces the left ventricular elasticity and it increases blood flow. It increases oxygen consumption and it increases the myocardial workload and mortality. Okay. Mechanical valve replacement, tissue valve replacement, and Rose procedure. Valve, it is easy to insert. It has excellent durability and it makes some noise and it increase the risk of bleeding and coagulation tendency, thromboembolic embolic tendency. So patient has to take warfarin for the whole life. And in tissue valve, it is noiseless. It is easy. It is difficult to insert, but it reduces low risk of thromboembolism and bleeding. Insert may be difficult. Okay, yes. Balloon valvuloplasty, transcatheter aortic valve replacement, transcatheter aortic valve replacement, and aortic valve balloon valvuloplasty. Transcatheter. Mm-hmm. I will remove the valve because the valve will be a septic focus and the valve will be dehiscent, and as there will be no blood supply, it will form a biofilm and it will be difficult to treat with the antibiotic. It means it is a fungal infection. Mainly, it is Candida aspergillosis, Microsporium, Trichophyton, Epidermophyton. Candida aspergillosis, CAME. Chemitri, CAME, chemitri. Candida aspergillosis, Microsporium, Epidermophyton, Trichophyton. Candida aspergillosis, Microsporium, small spore, so it is microsporium. Candida aspergillosis, Microsporium, Trichophyton, Epidermophyton. Candida aspergillosis, Microsporium, Trichophyton, Epidermophyton. Maybe there is thromboembolism, which leads to cerebrovascular stroke. Thromboembolism, which leads to cerebrovascular stroke. Yes, warfarin. Okay. No, this answer we will give like this way. Yes, depends on the type of valve replacement. If it is mechanical valve replacement, we prescribe warfarin for the lifelong. But if it is tissue valve replacement, we prescribe for 3 months. Yeah, it is better answer. Warfarin, it inhibit vitamin K dependent clotting factor 27910. It inhibit vitamin K dependent clotting factor 27910. So pathway it will inhibit intrinsic pathway. In intrinsic pathway it will inhibit. So which warfarin? Oh, sorry. Mode of affection inhibit 27910 and 27 mainly 7 is the pathway of the extrinsic pathway. 2 and 7 these are the extrinsic pathway mainly 7. So they will affected, yes. But if they ask which pathway will be affected, that is factor 10 with the help of factor 5 will transform prothrombin to thrombin, and thrombin will cause fibrinogen to fibrin, and it activates factor 13 to form cross-linked fibrin clot. Activates factor 13 to form cross-linked fibrin clot. Again, activated factor 10 with the help of activated factor 5 will transform prothrombin to thrombin, and thrombin will cause activation of hydrolysis of fibrinogen to fibrin, fibrinogen activation of factor 13, which will cause uh, fibrin-rich clot formation, cross-linked fibrin clot, cross-linked CLFC, cross-linked fibrin clot. Okay, again, activated factor 10 with the help of activated factor 5 transform prothrombin to thrombin, which causes hydrolyzation of fibrinogen to fibrin, and it activates factor 13 to form cross-linked fibrin clot. Hmm. Thrombus is a product of floating pathway which is formed by the constituents of the blood and remains in the same position. Product of the clotting pathway, which is formed from the constituents of the blood and remains in the same position. Product of the clotting pathway. Product of the clotting pathway formed from constituents of the blood and remains in the same position. Thrombus, infection and inflammation. Infection, inflammation. Thrombus, it may have infection and inflammation. Thrombus may have infection and inflammation. CBC, CRP, ESR, and blood culture. CBC, CRP, ESR, blood culture. For the thrombus, infected thrombus, we will do inflammatory markers like CBC, CRP, ESR, CBC, CRP, ESR, and blood culture. CRP is a acute phase protein which is produced by the liver in response to inflammation. It is a acute phase protein which is produced by the hepatocyte in response to inflammation. Okay. There is one question. You skip. What you will look for in the blood culture. The common organism like Staphylococcus aureus, Staphylococcus epidermidis, also has a group of inflammation microorganism like Haemophilus species, Aggregatibacter species, Codibacterium hominis, Echinella, and Kingella. HACEC, HACEK. H for Haemophilus influenza, A for Aggregatibacter, C for Codibacterium, E for Echinella, K for Kingella. Again, Haemophilus species, Aggregatibacter species, Cardibacterium hominis, Echinella, Kingella. From hepatocyte. From hepatocyte. Liebman-Sachs endocarditis. NICE guideline and sign guideline. NICE guideline says if a patient going for any infected procedure like upper GI or lower GI surgery, then can give antibiotic, or if it is a major procedure. And sign guideline says no antibiotic at all. But can you see microscopically in infective endocarditis? Eschop's body is in all three layers of the heart. Eschop's body, a form of granulomatous inflammation. Eschop's body, a form of granulomatous inflammation uh, in the all three layers of the heart, that is epicardium, myocardium, and endocardium. Eschop's body in a form of granulomatous inflammation in all three layers of the heart, that is epicardium, myocardium, and endocardium. I I, I cannot remember this. To be very in example, simply Ashok's body, if I can remember, Shukriya. Ashok's body, which is a form of glandular inflammation and found in all three layers of heart, epicardium, myocardium, and endocardium. Consists of central zone of degenerating extracellular matrix, consisting of central zone of degenerating extracellular infiltrates by lymphocytes, plasma cell, and anti-shock cell. Extracellular, okay, lymphocyte and plasma cell. Okay, Ashev's body, a form of granulomatosis inflammation with lymphocyte and plasma cell, and all three layers of heart. Okay. Hmm. In the hands, we have ocular nodules, which is painful, genuine lesions, which is painless, and splinter hemorrhage. So OGS. Ocular nodule, painless, ocular nodule. It is painful. Sorry, ocular nodule, genuine lesion, splinter hemorrhage, and clubbing. Ocular nodule. It's painful. Genuine lesion. It is painless. Splinter hemorrhage and clubbing. Okay. What is aortic sclerosis? It is a AV valve disease with insignificant gradient across the valve can progress to stenosis. It is arteriovenous valve disease, or it is AV valve disease with insignificant gradient across the valve can progress to stenosis. It is AV valve disease with insignificant gradient across the valve can progress to stenosis. Okay. A 76-year-old female referred for temporal artery transient loss of vision in one eye. Transient loss of vision in one eye. Well, mainly the branches of the external carotid artery. It is a granulomatous inflammatory disease which affects the large and medium-sized base of the external carotid arteries. In giant cell arteritis, there will be intimal thickening and internal elastic laminar fragmentation, intimal thickening, internal elastic lamina fragmentation, intimal thickening, internal elastic lamina fragmentation, infiltration of the T cell, macrophage, and multinucleated giant cell. Infiltration of the T cell, macrophage, and multinucleated giant cell. Again, it is a intimal thickening, internal elastic lamina fragmentation. Two things, and last is infiltration by T cell, macrophage, and multinucleated giant cell. Again, it is intimal thickening, internal elastic lamina fragmentation, and infiltration of the T cell, macrophage, and multinucleated giant cell. What is the causes of loss of vision? Because of involvement of the ophthalmic artery, which gives the central retinal artery. Because of involvement of the ophthalmic artery, which gives the central retinal artery. ESR and CRP. If patient diagnosed, then immediately we start with prednisolone 60 milligram per orally. But if patient present with some complication like MRSS, PGIS, or loss of vision, then we start IV methylprednisolone 80 milligram IV, and we continue the treatment for 2 years. OD or IV methylprednisolone. Yes, it is. Wait for the biopsy report. Blindness. Hmm. Okay. Thank you. Then, with fracture necrofemour, what are the possible risk factors for pathological fracture in this patient? In this patient, because she's a aged patient, postmenopausal patient, woman, and she is on steroid therapy for a long time. So, steroid therapy, old age female, postmenopausal. Osteoporosis and avascular necrosis. It is Paget's disease, phone, PM, is hyperthyroidism, osteomalacia. Yeah, PHON, PM. Like this, we can remember it. Other causes. One is Paget's disease, hyperparathyroidism, osteomalacia, and neoplasm, primary and metastatic. Also steroid, phones, PHONES, or secondary or pathological fracture. Risk factor. This N has again primary and metastatic. Okay, then we can remove S, phone. What other local risk factor? Yes, Pages Perry. Normal bone will be normal in the type and mineralization, but decrease in overall bone volume. Bone is normal. This is overall bone volume. Steroid coverage, perioperative concentration need to be in steroid coverage to avoid relapse and to avoid additional crisis and electrolyte disturbance. Perioperative concern, steroid coverage to avoid perioperative coverage to avoid relapse of the disease, to avoid additional crisis and to avoid electrolyte disturbance. Shortness of breath, petechial rash, diagnosis, fat embolism. What is the pathogenesis of fat embolism? Disruption of the fat droplet into by trauma, disruption of the fat droplet by trauma, and lead to its direct release into the vascular circulation and occlusion of the microvasculature. Okay, disruption of the fat droplet by direct trauma and release of this fat particle into the circulation and the of the bone. Protein matrix. Osteoid is a protein matrix secreted by osteoblasts that form the organic matrix of the bone. Osteoid is a protein matrix. Osteoid is a protein matrix secreted by osteoblast. It is a protein matrix secreted that form the organic matrix of the bone. What are the risk factors for osteomalacia? Vitamin D deficiency, malabsorption, renal failure, steroid therapy. Vitamin D deficiency, malabsorption, renal failure, steroid therapy. Vitamin D deficiency, malabsorption, vitamin D deficiency, malabsorption, renal failure, and steroid therapy are the causes of osteomalacia. What is the protein deposit in this patient amyloid AA? Why? Because it is because of its hard arrangement of the protein, very hard to degrade by the body enzyme, and kidney cannot excrete this protein. ESR blood taken in the there is no adjacent inflammation, and it is cellular content intact, and nucleus undergoes nucleosome, no adjacent inflammation, and mostly it is a physiological process. And necrosis, cell size enlarge, opposite, cell size enlarge, plasma membrane disrupt, cell content, enzymatic digestion, and may leak out of the cell. Okay. Good point. Enzymatic digestion and may leak out of the cell. We can say lysis, karyokepnosis, hexis, and lysis. Kepnosis, hexis, lysis. Karyokepnosis, karyohexis, karyolysis. Karyokepnosis, karyohexis, and karyolysis. So again, apoptosis and necrosis. In apoptosis, cell reduce in size, plasma membrane intake, cellular content intake, nucleus fragmentation, and into nucleosome, no adjacent inflammation, and it is mostly physiological process. And necrosis, cell size increase, plasma membrane disrupt, cellular content undergo enzymatic digestion and may leak out of the cell. Nucleus changes, karyokepnosis, karyohexis, karyolysis, adjacent inflammation, and mostly it is a pathological process. Mention types of gangrene, dry gangrene, and wet gangrene. Dry gangrene, mostly it occurs due to arterial occlusion in the limb, and uh, mm, there will be the skin, the organ becomes and black. Organ becomes dry, shrunken, and black, and putrefaction limited due to very little blood supply, and clear line of demarcation present between the healthy and gangrenous part. Dry gangrene, it occurs due to arterial occlusion, so mostly it happens in the limb, and the organ becomes dry, shrunken, and black. Dry, shrunken, and black, and putrefaction limited due to because of very little blood supply. Putrefaction limited due to little blood supply, and line of demarcation present between healthy and gangrenous tissue. And bacteria fail to survive. Prognosis usually better due to little septicemia. Bacteria fail to survive. Prognosis generally better due to little septicemia. At least four difference we can say. And weight gangrene, it occurs due to venous obstruction, mostly occurs in the bowel. So part becomes moist, soft, swollen, rotten. Moist, soft, swollen. The limb becomes a dry, black, and shrunken. Better. And weight gangrene, weight gangrene, it occurs due to venous occlusion, mostly occurs in the bowel. So part become moist, swollen, soft, and dark. Putrefaction marked because of uh, stiffening of the organ with blood, and no clear line of demarcation. Numerous bacteria present, and prognosis is bad. Gangrene surrounding the area shows redness. What is the pathological process? Due to post hypoxia dilatation. Hypoxia dilatation of foam cell lymphocyte. What are the pathological cells present in the atheroma? There are foam cell and lymphocyte. Lymphocyte. Apart from hypertension, diabetes, and male sex, what are the three major risk factors for atherosclerosis? Hypertension, diabetes, and male already gone. So remaining is the increased age and hyperlipidemia. Hypertension, diabetes, male. Apart from these, hypertension, diabetes, mellitus. Then we have family history, advanced age, and hyperlipidemia. Smoking, family history, increased age, and hyperlipidemia. Which size and type of the vessel are affected in atherosclerosis? Large and medium-sized artery. Patient shows X-ray with purple pleural plaque. What is are pleural plaque? These are well circumscribed plaque of dense collagen that are often calcified. These are well circumscribed plaque of collagen. They are well circumscribed plaque of dense collagen, well circumscribed plaque of dense collagen that are often calcified, and it increases the risk of mesothelioma and bronchogenic carcinoma. Classification: small cell carcinoma, non-small cell carcinoma. Small cell carcinoma, non-small cell carcinoma. Non-small cell carcinoma, we have squamous cell carcinoma, large cell carcinoma, adenocarcinoma. And best prognosis in order. Slum dog millionaire. Slum is squamous cell carcinoma, large cell carcinoma, adenocarcinoma, small cell carcinoma. Small, named small, but it is bad. Where it was found, poorly differentiated. How to differentiate the tissue of origin? Immunohistochemistry. If tumor marker is epidermal growth factor positive, what chemotherapeutic agent is appropriate to use? Tyrosine kinase inhibitor. Tyrosine kinase inhibitor like imatinib. Mentioned type of necrosis: coagulative necrosis, gaseous necrosis, liquefied necrosis, gas necrosis, fibrinoid necrosis, fat necrosis. Coagulative CC, LG, FF. CCLGFF. Coagulative necrosis, caseous necrosis. Liquefied necrosis, gangrenous necrosis. Fat necrosis, fibrinoid necrosis. What is adenocarcinoma tumor formed from the glandular structure in the epithelial cell? It is a malignant tumor of the epithelial tissue which takes the glandular pattern. What is emphysema? Abnormal permanent dilatation of the air space. Dilatation of the air space distal to the terminal bronchiole, abnormal permanent dilatation of their wall without fibrosis, destruction of their wall. They will break the wall, but they will not make the fibrosis, as like Gaza. They break the building, but they are not repairing, and they are not making dilatation. If their elasticity is preserved, then their permanent dilatation will not be there. Emphysema is the abnormal permanent dilatation of the ear space distal to the terminal bronchiole with destruction of their wall without fibrosis and destruction of their lung parenchyma with loss of elasticity. What is paraneoplastic syndrome? It is a symptom complex that occurs in a patient spread of the tumor or by the elaboration of the hormones indigenous to the tissue of origin of the tumor. Local or distant spread of the tumor or by the elaboration of the hormones. Local or distant spread of the tumor or by elaboration of the hormones indigenous to the tissue of the origin of the tumor. What are the hormones related to the cancer? Small cell lung cancer, small cell, which is very bad, very bad, very bad. Small cell lung cancer, ACTH, ADH, ACTH and ADH, and squamous cell lung cancer, PTH hormone related peptide, PTH related peptide causing hypercalcemia. Hypercalcemia. Okay, small cell lung cancer, adenocorticotropic hormone and ADH, ACTH. Small cell lung cancer, ACTH and ADH, ACTH and ADH, and small cell lung cancer, squamous cell lung cancer, the PTH related peptide causing hypercalcemia. What is TNF? Cytokines, which is produced by the macrophage. TNF high temperature and high inflammatory markers and has anti-tumor effect because its name is tumor necrotic factor. It is a pro-inflammatory cytokine which is produced by the macrophage and causing high temperature and high inflammatory markers. Causing high temperature and high inflammatory markers, it has anti-inflammatory effect. It is a pro-inflammatory cytokine produced by the macrophage, causing high temperature and high inflammatory markers and has anti-tumor effect. What is the significance of PDGFRA gene? Platelet-derived growth factor receptor alpha. Platelet-derived growth factor receptor alpha. It gives the instruction to make a protein which is called platelet-derived growth factor receptor alpha. Okay. From foreign travel Bangladesh with cervical lymphadenopathy, loss of weight, and night sweats. Two main differential diagnoses will be Hodgkin's lymphoma and tuberculosis. Hodgkin's lymphoma and tuberculosis. Then Hodgkin's lymphoma. Things. Young Hodgkins and old will be non-Hodgkins. Microbiology plus cytology. Microbiology plus cytology. Which lab you will send? Microbiology and cytology. We will do PCR quantiferon, which is interferon gamma assay and recombinase polymerase amplification. Recombinase polymerase amplification, PCR, recombinase polymerase amplification, and interferon gamma assay. I'll put the specimen in biohazard bag, which is red colored, labeled as category B UN 3373. In a biohazard red color bag labeled as category B UN 3373. It is Mycobacterium tuberculosis, Mycobacterium avium, intercellulary, Mycobacterium bovis, Mycobacterium ulcerans. Mycobacterium tuberculosis, avium, intercellulary, Mycobacterium bovis, Mycobacterium ulcerans. FNSC result which showing necrosis and histiocyte and giant cell. If necrosis, histiocyte and giant cell, this is the granuloma. So it could be tuberculosis because cell. If this is, it is granuloma, so it is most likely to be tuberculosis. Amyloid AA. Giant cell is a multinucleated cell which is formed by the fusion of the monocytes and forming granuloma. It is a multinucleated cell. It is a multinucleated cell which is formed by the fusion of the monocytes or macrophage and forming granuloma. Forming granuloma, it is optional. If we say not, no problem. It is a multinucleated cell which is formed by the fusion of the macrophages or monocytes and they of forming granuloma like Langerhans giant cell, red Steinberg cell, leprosy and rheumatoid arthritis. Also foreign body. Fungal infection, foreign body. FF, fungal infection, foreign body. Fungal infection, foreign body. Fungal infection, foreign body. Crohn's disease, tuberculosis, leprosy, rheumatoid arthritis. Crohn's disease, tuberculosis, leprosy, rheumatoid arthritis. Fungal infection, foreign body. Crohn's disease, tuberculosis, isolation of the patient and notify consultant in communicable disease control and notify health protection agencies. So two, one is notify consultant in communicable disease control consultant and health protection agency, communicable disease control consultant, communicable consultant in communicable disease control and health protection agency and give anti-tubercular medicine and contact tracing whom the contact tracing for what? The identification and diagnosis for whom? The person who may have come in contact with an infected person for the last 21 days. Again, isolation of the patient, notify consultant in communicable disease control, notify health protection agency, start anti-tubercular medicine, and contact tracing to identify who might have come in contact with this infected person in last 21 days. Okay. Montauk's test. Montauk's test. Empty test, or Montauk's test. What type of test to do for the detect tuberculosis? Montauk's test. Empty test and piece. Montauk's, Montauk's, Montauk's test and PCR. Yeah, PCR, quantiferon, gamma, and recombinase polymerase amplification. Those things also you can say. Same, no difference. No difference at all. Okay, what is the type of test? you to do to detect tuberculosis. Quantiferin gamma assay, recombinase polymerase amplification, and PCR. What are the type of pathological immunoresponse in pathogenesis of tuberculosis? Type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction. We will do type 4. This is a type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction. Okay, you are there. Hello. Yes. Mm-hmm. Waiting. I have no luxury. Sleeping. Sleeping is like a luxury now. Enjoying. You have that option now. I'm saying sleeping is like a luxury. Luxury means entertainment. I don't have that option now. Okay. Okay. So what type of pathological immunoresponse in pathogenesis of tuberculosis? This is type 4 hypersensitivity reaction. Type 4 hypersensitivity reaction. Here in UAE, now the weather becoming hot. No, it's okay. I'm saying in UAE now weather is becoming little hot, so we need to use AC from now starting. Okay. Mm-hmm. Okay, let's finish. In next speed, we will finish three station rapidly. Okay. So one thing you can do, you are joining from mobile, laptop, or tab. Okay. You are okay. Four means my six. Uh, okay. Okay. So when I read that time, if you also want to repeat it, I mean, if you want to say, then maybe you can put mic off and you can say, then when again I say like that. So you okay, good. Then do that one. O- Okay, okay. No worries. Okay, next session. I will try to be fast. Okay, female who underwent mastectomy for breast tumor 5 years ago, as well as parotidectomy for pleomorphic adenoma 10 years ago. Now she presented with supraclavicular lymph node enlargement. Okay. So what investigation we will do? We will do biopsy either true cut or core biopsy or excisional biopsy. We will do tissue biopsy either by true cut, core biopsy or excisional biopsy. Imaging we will do MRI and mammogram for the opposite side. MRI and mammogram for the opposite side. What test to be done on FNA? We will do immunohistochemistry and fluorescence in situ hybridization. FISH. Fluorescence in situ hybridization, immunohistochemistry and fluorescence in situ hybridization, immunohistochemistry and fluorescence in situ hybridization. Fish for the breast fish, fluorescent, okay, and hormonal receptor, ERPR and HER2 receptor. So we will do immunohistochemistry, fluorescence in situ hybridization test, hormonal receptor like ERPR and HER2 receptor. Which receptor? HER2 receptor is poor prognosis. HER2 poor prognosis, but ERPR receptor is good prognosis because we can treat with the hormone. Why is ER important? It is important because of the prognosis of the patient and the treatment strategy. Why ER important? Because of the prognosis, because of the prognosis and treatment strategy, because of the prognosis and treatment strategy, because of the prognosis and treatment strategy. Prognosis and treatment strategy. What is HAR2? transmembrane human epidermal growth factor. Transmembrane human epidermal growth factor 2, HER2, human epidermal growth factor 2. They are oncogen and biomarker. Okay, HER2. What is HER2? It is a transmembrane human epidermal growth factor receptor 2. They are oncogen and biomarker, and it is overexpressed in 15% of the breast cancer and associated with bad prognosis. They are less likely to be sensitive to the hormonal therapy. Okay, so overall, what is HER2? It stands for epidermal endothelial. Epidermal growth factor receptor 2. Transmembrane human epidermal growth factor 2. It is oncogen and biomarker and overexpressed in 15% of the breast cancer and associated with bad prognosis because they are less likely to sensitive to hormone therapy. It is a transmembrane human epidermal growth factor receptor 2, oncogen and biomarker. It is overexpressed in 15% of the breast cancer patient associated with bad prognosis, but they are less likely to be sensitive for the hormone therapy. Difference between tissue under microscope and cytology is the study of cellular structure and function. Cytology is the study of the cellular structure and the function, and histology is the study of the tissue and the under microscopy. When cytology is deemed inconclusive, if insufficient cell, blood, or inflammatory cell covering the target cell to be examined, poor fixation or staining preventing an inadequate or absent level of the sample. C1 to C1, 2, 3, 4. C1 is inadequate sample. C1 inadequate sample. C1 inadequate sample. C2 benign. C1 inadequate sample. C2 benign. C3 equivocal. C3 equivocal. C3 equivocal. And C4 suspicious sample. C2 benign. C3 equivocal. Equivocal. C4 suspicious. C4 suspicious. C5 malignant. C1 insufficient sample. C2 benign. C3 equivocal. C4 suspicious, and C5 malignant. What tissue is the malignant tumor of the epithelial tissue which takes the form of a glandular structure? What is the relevant features? And it share with the salivary gland some morphological and functional features. Some morphological and functional features, and they express share some gene like breast cancer and salivary and A, and for A and salivary gland is and expression E gene. Breast cancer and salivary gland expression gene. Breast cancer and salivary gland expression gene. Also, they share BRCA1 and BRCA2. So, breast is considered as modified sweet gland, and it share with salivary glands some morphological and functional similarity, and they have some gene similar gene like breast cancer and salivary gland expression. Salivary the hormone therapy to be given in pre and post pre-operative tamoxifen, anostrozole, postmenopausal jol, anostrozole, premenopausal tamoxifen, postmenopausal disease or eczema, Paget's disease or eczema, Paget's disease or eczema, Paget's disease or eczema. What is the pathophysiology of Paget's disease? Paget's disease, okay, mainly it is caused by the extension of the ductal carcinoma in situ up to the lactoferous duct. It is caused by extension. It is caused by extension of the ductal carcinoma in situ up to the lactoferous duct and into the contiguous skin of the nipple. It is the extension of the ductal carcinoma of the situ. Paget's disease. Paget's disease is the extension of the ductal carcinoma in situ up to the lactiferous duct and into the contiguous skin of the nipple. Casting exudative over the nipple and the areolar skin. 3. Unilateral crusting exudative over the nipple and the areolar skin. Again, it is the extension of the ductal carcinoma of the situ up to the lactiferous duct and into the contiguous skin of the nipple. It is the extension. It is the extension of the. It is the extension of the. It is the extension of the ductal carcinoma of the C2. It is the extension of the ductal carcinoma of the C2 up to the lactiferous duct into the contiguous skin of the nipple, producing unilateral crusting exudative over the skin and the nipple. End of discussion. What is the most common type of breast cancer? Invasive ductal carcinoma. Case of proximal fracture, proximal of breast cancer and mastectomy 5 years ago. Case of proximal femur fracture, known case of hyperparathyroidism, history of breast cancer and mastectomy 5 years ago. Check lab result and check the abnormalities. Increase urea. One second, doctor. Okay. Uh, Check the lab and check the abnormalities like increase urea, creatinine, hypercalcemia. Okay. Uh, Causes of proximal femur fracture, known case of hypothyroidism, and history of the breast cancer, mastectomy 5 years ago. Check the lab result. Lab result: increase urea, increase creatinine, and hypercalcemia. Hypercalcemia. So two possible cause of hypercalcemia. One is creatinine. So um, mm, chronic kidney disease, and local bone metastasis. Chronic kidney disease and local bone metastasis. Chronic kidney disease and local bone metastasis. Chronic kidney disease and local bone metastasis. Chronic kidney disease, local bone metastasis. Two possible causes of hypercalcemia: chronic kidney disease, local bone metastasis. What to look for in bone scan? In bone scan, we'll look for highly metabolic activity or hot spot. Area of increase. In the bone, we will look for area of in the bone. We will look for area of in the bone. We will look for area of in the bone. We will look for area of increased metabolic activity, which is called hotspot. In the bone, we will look for area of increased metabolic activity. Okay. What you will look for in the bone? In the bone, we will look for area of hotspot. Increase metabolic activity. Area of increased metabolic activity or hotspot. Because of the metastasis and hypothyroidism. Because of the metastasis and hypothyroidism, there is increased risk. Hypothyroidism. Because of the metastasis and hypothyroidism, there is increased risk of non-union and failure to fixation. Also, high risk of infection and immunocompromised. High risk of infection and immunocompromised. Of metastasis and hypothyroidism, there is increased risk of non-union and failure of the fixation compromised. Why will you send the head of the femur for the pathology to see the presence of any metastasis? Also to know the type of the malignancy and the cause of pathological fracture. Three, type of malignancy present and the cause of pathological fracture. What is the mechanism of action of radiotherapy? Radiotherapy it diminishes the osteoblastic activity. It diminishes osteoclast activation, and it diminishes osteoclast activation. It diminishes osteoclast activation, and it diminishes osteoclast activation and kill tumor cell by two mechanisms. Kill tumor cell by damaging the DNA of the cell. Okay. So radiotherapy diminish osteoclast activation, and kill the tumor cell by damaging DNA in two mechanisms. One, direct action directly damage the DNA, causing the cellular death, and indirect, they form the free radicals, and these free radicals causes the cellular death. So they diminish osteoclast activation and the kill tumor cell. After resection to kill any cell that might escape, and used in low dose in radiation in the X-ray. For function, reduce the size of the tumor before surgery. After surgery, if there is any remaining tumor, radiotherapy can kill the cell and to relieve the pain, and low dose of radiation is used in X-ray again to reduce the tumor volume before surgery. After surgery, if there is any remaining cancer cell, it can kill those cells and relief of the pain, and used in low dose radiation in X-ray. Give three cause of pulmonary embolism and DVT in this patient after total hip replacement. Postoperative immobilization, coagulative state due to cancer, hypercoagulative state due to cancer, and postoperative immobility and venous stasis during surgery. Venous stasis due to surgery. Three. One is postoperative immobilization, hypercoagulability due to malignancy, and venous stasis during surgery. Two medications for the breast cancer. Two medications for the breast cancer. We can give if the patient is a premenopausal, we can give tamoxifen, and postmenopausal and Herceptin. Okay. Herceptin mechanism of action and how it works. Herceptin is a monoclonal antibody, and it causes antibody mediated destruction of the cell which overproduces HER2. Herceptin is a monoclonal antibody. Monoclonal antibody, it causes antibody mediated destruction. It is a monoclonal antibody. It is a monoclonal antibody. It is a monoclonal antibody, and it causes antibody mediated destruction of the cell which overproduces HER2. What is the regimen of Herceptin? Three times weekly for 12 months. Three times weekly for 12 months. Why aromatase inhibitor not given? Aromatase is postmenopausal. Okay. Why not given in premenopausal? Because high level of estrogen produced by the active ovaries cannot suppress, because high level of estrogen produced by the ovaries, which makes suppression ineffective. Okay. Because high dose of estrogen produce aromatase inhibitor, and the high level of androgen comparing competing with aromatase inhibitor for the aromatase enzyme. High dose of androgens. One high dose of androgen competing with the aromatase inhibitor for the same receptor. High level of androgen competing with the aromatase inhibitor for the aromatase enzyme. Okay. Man 1 syndrome. 44-year-old female, history of mild asthma and parathyroid surgery. Intermittent 44-year male patient present in the clinic, history of mild intermittent abdominal discomfort and pancreatic disease is being considered. Okay. Define parathyroid hyperplasia. Parathyroid hyperplasia is the enlargement, non-malignant pathology in which there is proliferation and enlargement of the parathyroid cell. It is a non-malignant. It is a non-malignant It is a non-malignant pathology. It is a non-malignant pathology in which there is proliferation and enlargement of the parathyroid cell. Non-malignant pathology. It is a parathyroid hyperplasia. Parathyroid hyperplasia is a parathyroid hyperplasia. It is a non-malignant pathology in which there is proliferation and enlargement of parathyroid cell. It is a non-malignant. It is a non-malignant pathology in which there is proliferation and enlargement of parathyroid cell. How many parathyroid glands are affected? Four parathyroid glands. Microscopic picture of parathyroid hyperplasia. There will be chief cell hyperplasia, chief cell hyperplasia with water clear cell hyperplasia. Chief cell hyperplasia most common pattern. Chief cell hyperplasia most common pattern. Also less commonly water cell hyperplasia. Chief cell hyperplasia most common pattern. Chief cell hyperplasia most commonly pattern. Also there is one is chief cell hyperplasia most common pattern, and less commonly water cell hyperplasia. In many circumstances, islets of oxyphil and delicate fibrous strands, islets of oxyphil and delicate fibrous strands. Okay, so chief cell hyperplasia is the most common pattern. Also, less commonly water cell hyperplasia. Chief cell hyperplasia most common pattern, and less commonly water cell hyperplasia. In many circumstances, fibrous strands may envelop the nodules. Define the two top regions of parathyroid hyperplasia. Two top regions of parathyroid hyperplasia. One is renal failure. Another one, man syndrome. Renal failure and man syndrome. Renal failure and man syndrome. Renal failure, man syndrome. Okay. Envelope the nodule. Define two top regions of parathyroid hyperplasia on renal failure and man syndrome. The patient collapse in the clinic. His glucose level cannot be recognized immediately per liter by blood sample. It showed repeated attack of sweat, high detectable insulin level in the bloodstream. At the same time, high detectable insulin high detectable insulin level in the bloodstream. At the same time, high increased insulin glucose ratio and high level of. Apart from insulinoma, what other pathology can create this condition? Apart from insulinoma, what other pathology can create this condition? That is insulin-like growth factor. Growth factor, which produce from non-pancreatic tumor. Insulin-like growth factor, which produced from the non-pancreatic tumor. Insulin-like growth factor, which is produced from non-pancreatic tumor. Insulin-like growth factor. Insulin-like growth factor, which pancreatic tumor. Define man. Man is a condition. Group of related condition. Inherited and autosomal dominant, characterized by hyperplasia or neoplasia of the endocrine glands. Characterized by hyperplasia or neoplasia of the endocrine gland. Man is a group of related condition. Man is a group of related condition inherited as autosomal dominant. Man is a group of inherited condition. Man is a group dominant autosomal dominant, characterized by hyperplasia or neoplasia, both hyperplasia or neoplasia of the endocrine organ. Man is a man is a group of inherited condition character. In this patient, I will suspect pituitary adenoma. In this patient, I would suspect pituitary adenoma. In this patient, I would suspect pituitary adenoma. In this patient, I would suspect pituitary adenoma. Hmm? Mm-hmm. Okay, okay, okay. Hmm. Is a group of related condition inherited by autosomal group of related condition inherited by autosomal dominant, characterized by hyperplasia or neoplasia of the endocrine organ. What other pathology would you suspect in this patient? What are the gene mutation that happen in insulinoma? What are the gene mutation that happen in insulinoma? Menin gene and tumor suppressor genes such as P10, menin gene, tumor suppressor gene P10, menin gene, loss of function of ATRX and DAXS. Gene mutation happens in insulinoma. Gene mutation happens in menin gene and tumor suppressor gene such as PTEN, P10, tumor suppressor gene P10, and inactivation of the other gene like ATRX, DAXX. Suspect in this patient pituitary adenoma. What other pathology would you suspect in this patient? I will suspect for pituitary adenoma. Pituitary adenoma main one. Pituitary adenoma main one. Menin loss of tumor suppressor gene P10 and inactivation of the gene like ATRX and DAXX. What is two hit hypothesis in order for a particular cell to become cancerous? In order for particular cell to be cancerous, both the cells tumor chromosome telomere. It is the end of the chromosome which protects the end of the chromosome. It is a neighboring chromosome, and it is a reason of repetitive. It is a reason of repetitive nucleotide from being deteriorated or from being fused with the neighboring chromosome. And tumor suppressor gene, proto-oncogene, and microRNA gene, and mutatory gene like BRCA1 and BRCA2. Tumor suppressor gene, microRNA gene, tumor suppressor gene, proto-oncogene, microRNA gene, and BRCA1, BRCA2. Tumor suppressor gene, BRCA1 and BRCA2. Station 8, a young female, C, two names, so patient might have hypocalcemia. So I'm suspecting it is a medullary thyroid cancer. Thyroid cancer due to elevation of the calcitonin level. Medullary thyroid cancer due to elevation of the calcitonin level. Medullary thyroid cancer due to elevation of the calcitonin level. Medullary thyroid cancer, okay. Medullary thyroid cancer plus C cell, parafollicular C cell. What is mean parafollicular C cell? It is a method of localizing. It is a method of localizing specific antigen. It is a method of localizing in the tissue sample, and when these antibodies are bind to the antigen in the can barely seen under microscope, and the antigen can be seen under microscope. The antigens are bind with mm, mm, the antigens are bind with the tissue sample or enzyme. The antigens are bind when the antibodies bind to the antigen. Antigen can be seen under microscope. What are the type of antigen antibody recognition immunity classification of thyroid cancer? Here in the exam will be given size 3 centimeters. So 3 centimeter and within the capsule. So and some regional lymph node, no metastasis. So 3 centimeter it is T2 because up to 4 centimeter. In one because some lymph node and no metastasis M0. If the patient develops hypo, what are the other adrenal gland swelling, other adrenal gland swelling, infection like abscess, infection, and neuroblastoma, infection, abscess, trauma, hematoma, neuroblastoma, lymphangioma, and how can you diagnose pheochromocytoma? Pheochromocytoma in the plasma we can see catecholamine, free metanephrine, and catecholamine stimulation test. Catecholamine stimulation test, and free metanephrine in the plasma. In the plasma, stimulation test, and free metanephrine. Catecholamine and vinyl mandelic acid, fractionated metanephrine, total metanephrine. In plasma, catecholamine, free metanephrine, and catecholamine stimulation test, free metanephrine. And in the urine, we can see catecholamine and fractionated metanephrine, and ultrasound CT MRI, MIBG scintigraphy, MIBG scintigraphy, ultrasound CT MRI, MIBG CT, PET CT. If the condition is familiar, what other pathology you would suspect? Mutation in menin gene, chromosome number 11, man type 2A, man type 1, mutation in menin gene, chromosome number 11, man type 2A, mutation in red oncogene, man type 2B, mutation in red oncogene. Examination and investigation and staging. I will discuss with the multidisciplinary team to go for the thyroidectomy, for total thyroidectomy with the block neck dissection, with radical modified radical and selective radical modified radical and selective radical modified radical, sphere, internal jugular vein, sternocleidomastoid muscle, and frenulum 12 and selective. Yes. Wait. No, no, I'm just checking. My system also become little slow. Okay, after that is parotid tumor. After that, nasopharyngeal carcinoma, carcinate tumor, IBD, FAP, gastric cancer, uh, pseudomonas colitis, diverticulitis, endometriosis, peptic ulcer disease, esophageal carcinoma, gastric carcinoma, colon cancer, colon, hemorrhoids, malignant melanoma, malignant melanoma. Okay, 9 stations we have seen till now. This will be the station number 10. Okay. 60-year-old female presented at 60-year-old female patient at outpatient clinic. 60-year-old female patient presented at the outpatient clinic with unilateral palm facial swelling, raising at right earlobe. Facial nerve examination was normal. Facial nerve normal, so it is benign. What is the most probable diagnosis? Benign parotid swelling. Most probable diagnosis, benign parotid swelling. Most common benign parotid swelling, pleomorphic adenoma. What is the differential diagnosis of the unilateral parotid swelling? Infection like mumps, parotitis, neoplasm, benign metastatic, and duct obstruction by salivary duct calculus, or external duct compression, salivary duct obstruction, salivary duct obstruction, or external duct compression. What is the meaning of tumor? Variety of histological appearance, variety of histological appearance, variety of histological appearance, variety of histological appearance of stromal epithelial and myoepithelial cell, variety of histological appearance of stromal epithelial and myoepithelial element. Describe pleomorphic adenoma appearance. Variety of histological appearance. Variety of histological appearance of stromal epithelial and myoepithelial cell. Variety of histological appearance reflecting stromal epithelial and myoepithelial element. Mm, can pleomorphic adenoma turn malignant? Uh, how? How? What is the most common? Okay, parotid tumor. What is it? Can pleomorphic adenoma turn malignant? Yes. In 5% of the population progress called carcinoma. In 5% of the people, it progress called carcinoma, pleomorphic adenocarcinoma. How it occur? Due to accumulation of the mutation, it occurred in long-standing pleomorphic adenoma. Due to accumulation of the mutation, it occurred in long-standing adenoma, and it occurs in long-standing pleomorphic adenoma. With average age of recurrence after 20 years. It occurs in long-standing pleomorphic adenoma with average age of recurrence after 20 years. Average age of recurrence after 20 years, and had also uncertain etiology factors. Has an uncertain etiological factor, such as exposure to radiation and accumulation of the genetic susceptibility. In pleomorphic adenoma, can it turn into malignancy? Yes. Answer: it can turn into malignancy. How? In 5% population, it turned into malignancy called malignant adenocarcinoma. How? If it pleomorphic adenoma persists for a long duration. Number two, it how it occurs. Why? Screen is there. Hmm. Now. So, in 5%, it can progress to the carcinoma, like pleomorphic adenocarcinoma. How it occurs? By accumulation of the mutate if it recurs after 20 years, and some other factors like genetic susceptibility and radiation, exposed to radiation. What is the most common malignant parotid tumor? Mucoepidermoid carcinoma, mucoepidermoid carcinoma, parotid, most common malignant, hmm? Called carcinoma X pleomorphic adenoma. Okay, called carcinoma X pleomorphic adenoma. Okay. Okay, what is the most common malignant parotid tumor? It is mesoepidermal carcinoma, 15% mesoepidermal carcinoma. From your examination, what clinical signs would make you suspect malignant tumor, malignant transformation in a parotid swelling? The rapid increase in size fixed with the underlying tissue and the skin, presence of associated lymph node, facial nerve affection, and skin ulcer. The rapidly increase in size, presence of skin ulcer, involvement of the facial nerve fixed with underlying structure and overlying skin and associated with the lymph node invasion. Rapidly increasing size fixed with the underlying structure and overlying skin. Presence with associated lymph node and facial nerve affection and skin ulcer. What are the characters of a malignant neoplasm? Malignant neoplasm in general, rapidly increase in size, lack of differentiation, invading to surrounding tissue, metastasize to distant tissue. Fast, rapidly increase in size, lack of anaplasia, painless. Okay, rapidly increase in size, lack of differentiation, invade the surrounding tissue and distant metastasis. Simple test in the clinic, you need to differentiate FNAC. Simple test in the clinic help to differentiate FNAC. What are the cytological features that would raise concerns of the malignancy? From and again and giant cell and necrosis. Increase atypical mitosis, abnormal mitosis, lack of differentiation, hyperchromatism, increased nuclear cytoplasmic ratio, and increase and giant cell, presence of giant cell and necrosis and hemorrhage. Hemorrhage again. Atypical increase atypical mitosis, increase number of mitosis, increase atypical mitosis, um, hyperchromatism, increase nuclear cytoplasmic ratio, lack of differentiation, presence of hemorrhage and giant cell. What are the main difference between cytology and histology? What are the advantages of each? Cytology is the study of the cellular structure and the function. Study of the study of the cellular structure and the function, and histology is the study of the tissue under microscope. Okay. It is cytology. Advantages: cheap, easy, simple, quick result, and less invasive. It is cheap, simple, quick result, and less invasive. Disadvantage: it can give false negative. It can't give proper information about the tissue architecture. False negative cannot give the proper information about the tissue architecture, and it can be false negative. And histology advantages and disadvantages. Histology advantages, it is histology is more reliable, avoid unnecessary excisional biopsy. More reliable, avoid unnecessary excisional biopsy, give information about the tissue architecture. Avoid unnecessary excisional biopsy, give more information about the tissue architecture, can differentiate between the follicular adenoma and carcinoma, can differentiate between follicular adenoma and carcinoma. More reliable, avoid unnecessary excisional biopsy, give information about the tissue architecture, can differentiate between follicular adenoma and follicular adenocarcinoma. This is the histology and disadvantage. It is invasive procedure, operator dependent and expensive. Invasive procedure, operator dependent, and it is expensive. Necrotic material. This is a Langerhans giant cell, Mycobacterium tuberculosis, granuloma. Langerhans giant cell lymphocyte and necrotic material. This is Mycobacterium Mycobacterium tuberculosis, granuloma. Langerhans giant cell lymphocyte, necrotic material, tuberculosis, granuloma, brown pigmented cell. It is malignant melanoma with epithelial cell. Brown pigmented cell with epithelial cell, malignant melanoma, red Steinberg cell, red Hodgkin's lymphoma. Sensitive, it is the ability to test a individual who is diseased. Sensitivity, and the ability of the test to correctly classify, the individual as diseased. It is the ability of the test to classify. It is the ability of the test to correctly classify the individual as diseased. Sensitive. What is highly sensitive? Highly sensitive. It is the ability of the test to classify the false negative. Hmm. It is the ability of the test to classify the false negative, negative result, the false negative from the applied test population. What is the meaning of specificity? It is the ability of the test to correctly classify disease-free individual. It is the ability of the test to classify the individual as disease-free. What is high specificity test? It is the ability of the test to find out the false positive individual in the test population. Okay. How can you differentiate between carcinoma and lymphoma by immunohistochemistry? The dye or the enzymes are activated, and then the antigen can be seen under the microscope. How to rule out the malignancy intraoperatively? How it is done? By frozen section. Frozen section, and the section will be stained and reported immediately when the reports outcome. Doing FNSA needle prick injury occurred. They should and address incidence risk, assess incident risk, assess source patient by assess incident risk, assess source patient by taking history if he has possibility of any blood-borne infection. Take a blood sample from the patient if high risk after taking consent. I would file an incident report and speak to occupational therapy for advice and documentation. Okay. First, allow the wound to bleed under the running water and wash with the soap water and assess incident risk. Assess incident risk and assess the source patient by taking the history. If there is any possibility of bloodborne infection, take any blood samples for okay. What are the post-operative complications of parotidectomy? Parotidectomy is seventh nerve palsy, greater auricular nerve, or seventh nerve palsy, greater auricular nerve pulse damage, which can cause numbness of the ear lobule. Okay, seven nerve palsy, greater auricular nerve damage, which may cause numbness of the ear lobule, and Frey's syndrome and salivary fistula. Frey's syndrome, salivary fistula. Seventh cranial nerve palsy, greater auricular nerve, seven cranial palsy, greater auricular nerve damage, Frey's syndrome, and salivary fistula. What is the Frey's syndrome? What is the Frey's syndrome? This is the post salivary following salivary gland surgery, where there will be re-innervation of the post-ganglionic fibers. Re-innervation salivary gland. It is a post salivary gland surgery phenomena. It is a post salivary gland surgery phenomena. It is a post salivary gland surgery phenomena. which occurs due to re-innervation of the postganglionic fibers to the sweat gland and the cutaneous blood vessel. As a result, there will be gastatory sweating and flushing. From re-innervation of the postganglionic fibers to the sweat gland and sweat gland and the cutaneous sweat gland and the cutaneous blood vessel. As a result, there will be gastatory sweating and flushing of the face. 10 years after surgery, the patient presented with a neck swelling. What is your carotid body tumor and lymphoma? Carotid body tumor, possibility of the recurrence, 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 possibility of the recurrence with a metastasis, possibility of the recurrence with a metastasis, carotid body tumor and lymphoma. 55-year-old female with mastectomy done 5 years back and paratidectomy for a pleomorphic adenoma. What is the relation between breast and the pleomorphic adenoma? The breast is considered as multiple sweat gland, which share with the salivary gland some morphological and functional features like they share some gene like breast cancer and salivary gland expression gene base and share BRCA1 and BRCA2. How would you investigate clinically suspected pleomorphic adenoma by true cut biopsy or FNAC by FNAC or true cut biopsy by FNAC or true cut biopsy by FNAC or true cut biopsy by FNAC or true cut biopsy. What are the advantages of FNAC and true cut biopsy? FNAC cost effective, FNAC cost effective, simple, quick result, and mm, effective, simple, quick result, and less invasive. Cost effective, simple, quick result, and less invasive, and good when studying cell within fluid media on it. And true cut biopsy, avoid unnecessary excisional biopsy, more reliable. Avoid unnecessary excisional biopsy, more reliable. Grading and typing of the factor and relatively easy. It is more reliable, more reliable. Avoid unnecessary excisional biopsy. It is more informative and relatively easy. Relatively easy grading and typing of the factor. What test can be done in FNSC? FNSC we can do immunohistochemistry, hormone receptor, immunohistochemistry, fluorescence in situ hybridization test, breast fish, fluorescent in situ hybridization test, fish, immunohistochemistry, fish, then hormone receptor, ERPR receptor, and HER2 receptor. When inadequate sample mixed with blood and inflammatory cell, mislabeled, misstained. When FNAC sample is considered adequate, contain a minimum of free preserved cell group per slide. Contain a minimum of free preserve. Contain a minimum of free preserve. Contain a minimum of free preserved cell group. Contain a minimum preserved. Contain a minimum of contain a minimum of free preserved cell group and no fixed effect in TN smear. No fixation artifact. No fixation artifact in TN smear and no fixation artifact in tennis smear, no fixation artifact in tennis smear, no fixation artifact in tennis smear. What is the mention? What is the meaning of pleomorphic? Variety of histological appearance, variety of histological appearance reflecting stromal epithelial epithelial cell, variety of histological appearance reflecting stromal epithelial myopithelial cell. Variety of histological appearance reflecting stromal epithelial myopithelial cell. Describe pleomorphic adenoma people can turn into malignant cold. 10 years, it could be carotid body tumor, lymphoma, and recurrence of this ability to undergo vasoconstriction in response to injury. Can you define metastasis, survival and growth of a cell distant from its site of origin? Survival and growth of a cell distant from sited direct or continuous, direct or continuous extension, direct extension, presence, penetration into lymphatic blood vessel or body cavity, direct or continuous extension, first direct or continuous extension into blood vessel, lymph node or body cavity. So first direct or continuous extension, number two penetration into blood vessel, lymph node or body cavity. Number three, transport of the tumor cell into the circulation. Transport of tumor cell into the circulation. Transport of tumor cell into the circulation. Arrest in the capillary bed for secondary site. Arrest in capillary bed as secondary site, and growth of the disseminated tumor cell into the secondary site. First, direct or continuous extension, invasion of the surrounding lymph node, blood vessel, or body cavity, then transmit through the blood vessel, secondaries, and then growth of the disseminated tumor into the secondary site. What are the main routes of spread of the malignancy? Direct invasion, invasion, and distant. Direct invasion and distant spread by lymphatics, hematogenous, or transillumic. Lymphatics, hematogenous, transillumic, and other. Lymphatics, like carcinoma. Lymphatics carcinoma. Lymphatics carcinoma. Hematogenous sarcoma. Hematogenous sarcoma. Carcinoma হচ্ছে lymphatics. Direct lymphatics carcinoma. Hematogenous sarcoma. Transillumic. um, Along the body cavity to or peritoneal cavity, along the body cavity to peritoneal surface, along the cavity to peritoneal surface, and other perineal invasion. How does lymphatic spread occur? First, the tumor cell grow in its side without any control. Then it will penetrate the local tissue. First, the tumor cell grow in its side without any control. Then it will spread to the local tissue. Then grow through lymphatic. Then grow through the lymphatic to distal node. Then grow through the lymphatic to the distal node and embolization there. And then tumor will grow in the distant node. Okay, what are the mechanisms by which cancer cell promote lymphatic spread? Cancer cell release vascular endothelial growth factor C and D. It induce lymph angiogenesis in the primary tumor and in the draining sentinel lymph node. Then immunomodulatory molecules like exosome, which lead to immunosuppression. First, they release vascular endothelial growth factor C and D, and they initiates lymph angiogenesis in the primary site and the central draining lymph node, and the immunosuppression produced by the immunomodulatory molecules like exosome. Immunomodulatory molecules they release immunomodulatory molecules like exosome. Release of immunomodulatory molecules like exosome, which causes immunosuppression. Okay, now we are in nasopharyngeal carcinoma. We have finished 10 station, and now it is around 6:11. This is like prayer time here. And next, after 1 hour, we will again start, hopefully, for another 1 hour. Next session, we will try to finish. We finished 10. Still, we have. Hello. 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 Okay. Maybe you are busy. जय श्री कृष्ण चैतन्य प्रभु नित्यानंद श्री अद्वैत गदाधर श्रीवासादि श्री गौर भक्त बिंद हरे कृष्ण 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 हरे 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 राम 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 हरे हरे Hare Krishna, Krishna Krishna, Hare Hare, Hare Ramo, Ramo Ramo, Hare Hare. Hare Krishna, Krishna Krishna, Hare Hare, Hare Ramo, Ramo Ramo, Hare Hare. Jaya Vrinda Devi, Jaya Vrinda Devi, Vrinda Devi, Jaya Vrinda Devi.